everyone. Thank you for joining the webinar today. My name is Hannah. Today's webinar is POLST in the Nursing Home Setting. This webinar is part of our Toolkit series, using the POLST paradigm to honor patient treatment wishes across the care continuum. The preceding webinars in this series, each webinar covering a different setting, can be found at our website, polst.org/toolkit. And we are also recording today's session, so if you want to view it later, you can do so later today. We encourage you to ask questions at any time during the presentation today, and you can do so by typing your questions in the chat box. We'll answer most of the questions at the end of the presentation. I'd now like to introduce our presenters, Mercedes Bern-Klug and Nicole Peterson. Merce is a professor in the School of Social Work at the University of Iowa, and she also directs the Aging and Longevity Studies Certificate Program. Nicole is an adult and geriatric nurse practitioner and faculty member at the University of Iowa College of Nursing. And Nicole also teaches graduate and undergraduate nursing programs. And at this time, I'd like to go ahead and turn the presentation over to Merce and Nicole.
Thank you, Hannah. We just wanted to start a little bit with introducing ourselves and our involvement with IPOST, just to give you a little bit more information. So as Hannah said, I got my master's degree as advanced geriatric nurse practitioner in 2008. And at that time, Iowa was in the middle of their pilot project to go statewide with IPOST. And IPOST is the Iowa's version of POLST. And I was considering going on for my doctorate at that program, and actually was able to use for my doctoral project implementing the IPOST in one of our area nursing homes. Since then, I've been involved with a Hartford Change Agents grant with Mercedes Bern-Klug, as well as Jane Dorman, who's going to be presenting in the hospice chapter webinar. And then we also completed that grant, and then been involved with National POLST since that time. So I'm really excited to have been invited to work on this project.
Hi, I'm Mercedes Bern-Klug. I go by Merce. I'm here at the University of Iowa in the School of Social Work, and I also direct the Aging Studies program. I've been a long-term care researcher for about 15 years, and I focus mainly in the nursing home setting. And my main interests are looking at psychosocial issues related to medical decision-making, and especially surrogate or proxy decision-making on behalf of a frail elder. I've been trained in the Respecting Choices advanced care planning approach, and I volunteer as a advanced care planning facilitator at our local senior center. And as Nicole mentioned, she and I and Jane Dorman worked intensively with 2 local nursing homes to implement Iowa's version of the POLST paradigm. We worked with the nursing homes over the course of a year, and that was a very interesting and helpful learning experience for me. I'm also on the state task force for our IPOST, and I coordinate a listserv, the National Nursing Home Social Work Network listserv. We have about between 300 and 400 nursing home social workers who are part of this listserv, and often questions come up about advanced care planning and about the POLST paradigm. So I try to keep my finger on the pulse of things on that. Also, my mother benefited from using Iowa's version of POLST. A year ago, she passed away and was able to pass away at home, avoiding a trip to the emergency department, in part because of the use of the IPOST form here in Iowa. So I'm a firm believer of how this system can work when it works well. All righty. If you have questions today, go ahead and put the questions in the chat box. We'll get to them probably at the end. If you put the number of the slide that your question is about, then we'll be able to go back to that slide number when we take your questions. Just wanted to underscore that the purpose of today is to connect you with resources that can help you implement the POLST paradigm in your nursing home. So we're going to be talking a little bit about the POLST paradigm, a little bit about nursing homes, but mostly this webinar is to connect you to the resources and to help you realize that there is a lot of support available to help you do this in your own nursing home. And today we're going to focus on talking about the toolkit, especially the toolkit that is focused on nursing homes. So just right off the bat, if you're not that familiar with the POLST paradigm, know that there is a video that talks about the general approach to POLST, and that's on the National POLST website, and it explains how POLST fits in general in all different settings, and that's a really good review. Also gives you some language when you want to talk with other people about the POLST paradigm. And so if we are skipping over some concepts that you're not that familiar with that are related to POLST, please know that there's already a whole general webinar about what is POLST, and now we're talking about what it is in the nursing home setting. All right. The bottom line of POLST is to help support people's preferences. So POLST is a way that we can find out what it is that people who are close to the end of life, probably within a year of the end of life, how their feelings about their health situation, their prognosis, how they feel about their medical options, their values, their preferences. This is all about advanced care planning, and it's an informed approach to advanced care planning. And then the POLST form can fit into that advanced care planning because the POLST form with the conversation helps to clarify what it is that the resident, and for the purposes of this discussion, when I talk about people, I'm going to be talking about resident because we're talking about the nursing home setting, what it is that the resident would like to have happen. So it's a way to elicit people's wishes, a way to document them, and then honor them. It's intended for people who are seriously ill or frail, people for whom healthcare professionals would not be surprised if they died in the next 12 months. That's kind of the overall category. That's your target population. When the POLST form is completed and signed, it becomes an actionable medical order, and it becomes a medical order that directs current care. And if you'd like more information about the background, then please, after today's session, go back and listen to the general overview. I'm going to hand it over to Nicole now, but I'll be back toward the end of today's webinar. Thank you.
Okay, so let's consider a case, and I'll talk about this case over the next several slides. Let's think of a person who is an older adult who's been admitted to the nursing home following a stroke. There's a great diversity in what post-stroke symptoms look like. Some will have a full recovery with getting skilled rehabilitation, and they'll return home. Others will remain in the nursing home as permanent residents with a wide range of physical abilities following the stroke. For our case study today, I want you to think about the person who will remain a long-term nursing home resident as we present the information on the POLST paradigm in the nursing home. So in thinking about implementing the POLST paradigm in a nursing home, there are several unique issues to consider about this setting. Thinking about residents may have different cognitive impairments. You also have to consider family and surrogate decision makers. There's a lot of times very high staff turnover in nursing homes. The educational level of the staff does also vary. And a lot of times you have PRN staff or people who are there on a very short-term basis, sometimes only for one shift or two shifts or a weekend, who are not really familiar with the facility. There are huge interprofessional teams working with nurses, social workers, dietitians, physical therapists, occupational therapists. A lot of different people have really come together to take care of a person that's living in a nursing home. And a lot of times that's very huge staffing ratios between the number of staff and the number of residents that live there. And also the POLST form transfers between settings. So if you think about how often a person who lives in a nursing home goes between their clinic maybe to see their PCP, sometimes to the emergency room, maybe have a hospital stay, and then sometimes they leave and go to a different nursing home. So there's a lot of different systems challenges that come along with the different types of transfers that can take place for nursing home residents. So it's important that we start this conversation by thinking about making sure that we're engaging the right residents. POLST conversations are for people who their primary care provider would not be surprised if they died in the next year, like Merce said. So that's why it's important, first off, that we make sure that we're engaging the right people. Anybody who's coming to a nursing home for skilled rehabilitation who are expected to recover from whatever their acute illness or injury is and possibly go home, those people would not be appropriate. So that's why we want to focus on the people who are going to be the more long-term residents, and then also who we would not be surprised if they passed away in the next year. So this is a graphic that we have in our toolkit that makes it a little, try to make it a little simpler for people to understand who exactly we're talking about. So this is just a quick some examples of who would be appropriate and who would not be appropriate. So, people with broken bones or something and they're rehabbing, they're not appropriate because we usually expect them to recover and, still have a long life expectancy. Also, people with chronic stable physical disabilities, like, for example, a person with Parkinson's disease, they may need to live in a nursing home because they are no longer mobile and need some assistance, but their life expectancy is well beyond a year and could be 5 to 10 years. So they would not be appropriate for this conversation either. But then you have some people with final stages of medical illnesses, so thinking of things like heart failure, chronic obstructive pulmonary diseases, chronic kidney disease, other medical problems as well. So those people may be appropriate depending on their life expectancy. People with advanced Alzheimer's disease definitely would be appropriate. And then people who are in persistent vegetative states from any type of traumatic brain injury, for example, they would also be appropriate. Children also are appropriate except in the state of Colorado where people under the age of 18 are not included. So this is a review of the difference between receiving the standard of care versus an advance directive versus a medical order. And this is a review from previous webinars, and if you are not familiar with this, I would encourage you to go back and watch the overview webinar. But we're mostly talking about the difference between having a POLST is beyond just an advance directive and beyond a medical order of a DNR. It encompasses much more. And this is another slide from the overview webinar. Okay, so I'm going to share a little bit more information on a case that I actually took care of that I want you to think about. So we talked about this person who was admitted with a stroke. So let's think about she lived independently before she was hospitalized with her stroke. She's now completed her rehabilitation. She's having some paralysis, and she's wheelchair bound. She is requiring significant assistance with her activities of daily living. She has some swallowing dysfunction, but she is able to eat. She has some expressive aphasia, which makes her speech difficult. It's slurred. She has very few words, but she's able to still communicate her needs. Following this dramatic change in her level of her status, healthcare status, she quickly becomes withdrawn. She's engaged in POLST conversations, which included her son, who we're in the Midwest, and he lived on the East Coast, but he was here and was engaged in conversation. We'll touch base with her again in a little bit. So I just want to show you that these are the components of our Toolkit chapter pertaining to the nursing home. Today in this webinar, we are not going to be covering these in detail. I just wanted to make sure that you are aware of the information that you need to have, but these are the components that you'll find in the toolkit. Know that specific information, examples of policies and procedures, examples of audit tools, and a frequently asked questions section are all included in our toolkit. So while your policies and procedures may indicate that you should offer the POLST paradigm to any appropriate residents, it should not be a requirement that any resident complete a POLST form. So you can encourage the use, but you cannot make it a mandatory thing. It is always going to be a voluntary thing that a person can choose to engage in or not. So when to initiate conversations in nursing homes is a big question. So ideally, people would be coming to the nursing home already with a POLST form created, but we know we live in a real world and not the ideal world where that's not been happening just yet. We hope that in the future it is, but we want to be able to, when a person comes in, to assess them when we get there to see if they're appropriate. So on admission time, it is important, but anybody that works in a nursing home knows that admission is a really, really busy and hectic time for the resident, for their surrogate, for any family members that are involved. They're experiencing a change in their health status, a change in their setting, and it's usually a lot of times a pretty major change, so it's a little bit stressful. They might be coming from the home, they might be coming from the hospital, another level of care, such as in a senior apartment or assisted living. So basically we find three kind of categories of people related to assessing for POLST at the time of admission. So first, people who already have a POLST, and since being admitted to a nursing home is a change in their status, it is prudent to review the resident's wishes and determine if all of their wishes are still applicable at the time. If any of their wishes have changed, then new POLST conversations are warranted, but on admission day is not an appropriate time, so we encourage to set up a meeting to meet again with the residents and their family to discuss. Secondly, a person who does not have a POLST form, who is now appropriate based on their health status change, they should also have an appointment scheduled. Again, admission time is very hectic, so we know the best thing to do is to determine a time that is good for the residents and family that will allow them enough time to get settled in, adjust to the change a little bit, but schedule it soon enough so that it's not lost in the shuffle. So that's why we encourage scheduling an appointment when it's appropriate, but don't forget about it. And the third group of people are those that are admitted to the nursing home who are not appropriate for POLST at this time, but of course, any existing advance directives, including a DNR order, do need to be noted and documented. So next, quarterly care plan meetings are requirements for nursing home residents. This is a great time to assess the appropriateness of the POLST and review and then revise it if needed. This must be reviewed with, the POLST must be reviewed with any change in status of the resident as well as any changes in their goals of care. So nurses and licensed social workers who are trained in the POLST paradigm would usually be doing this because of the time commitment that is required for a care plan meeting. Sometimes it lasts all days, multiple days throughout the month. If a PCP provider is able to participate, this is a good opportunity for them to utilize the Advanced Care Planning CPT codes to bill for that time. And we're not going to go over that today, but if you want to go back and review the overview webinar, it gives really good information in there, as well as the primary care provider webinar. So let's think back to our case study. So POLST conversations took place with our resident when her rehabilitation had plateaued, and she was going to be discharged from skilled status, and then they were again reviewed when she had another change in her health status. So be sure to include surrogate decision makers and family members whenever possible. This can be done, like in our case study. We had a person who lived in the Midwest and her family lived on one of the coasts. So fortunately, her son had been in town because he was cleaning out her apartment because she was making a change. So we was able to be engaged in conversations. But for people who are not able to, travel frequently, you can have POLST discussions with people in person or over the phone or even using video conferencing, things such as Skype or FaceTime or something, technology that makes it easy for people to have a conversation. So when a resident lacks decisional capacity, we want the surrogate decision makers can complete a POLST or revise a POLST if that's necessary. Surrogates should be educated and reminded that their role as the surrogate is to make the decisions for the resident that they would make for themselves if they were able to communicate. So basically what the resident would want to have happen if they were able to speak for themselves. That's kind of a key component sometimes that we need to help the surrogate decision makers remember that is their role. So in order for the POLST paradigm to work effectively, the large interprofessional team in a nursing home needs to have really good communication skills among the team, lots of training and lots of education. So an important consideration for training in the nursing home setting is to decide who is responsible for screening for the appropriateness of POLST, who's responsible for the education about the POLST paradigm, and then who will be having the POLST conversation. So kind of deciding who will take on those roles. In the nursing home, the primary care provider is not always present. Sometimes the resident is cared for by the medical director instead of their normal primary care provider. And sometimes that's not the case. Sometimes it's the medical director and sometimes it's still the same primary care provider. Nurses and social workers are frequently present and they get to know the residents that live in nursing homes very well. It is appropriate for the nurse and the licensed social workers who are trained in the POLST paradigm to have conversations with the residents if they're acting within their scope of treatment. Physicians, physician's assistants, and nurse practitioners can bill Medicare depending on their state, whatever their state allows them, their scope of practice to be. They can bill using the Advanced Care Planning CPT code. And again, go back and review the Primary Care Toolkit webinar if you have not seen that yet for really good information on the CPT codes as well as the 8-step protocol for health professionals. It's a very good reference to use. Good documentation is another important training topic. Include documentation on what was discussed, who was present, and if a POLST form was completed or changed. That needs to be in a place that's consistent so everybody knows where to look for it. And then remember that training should be repeated frequently in a nursing home due to the high resident and staff turnover in nursing home settings. Some ideas for educating the residents is to include information on the POLST paradigm in the nursing home newsletter, on their webpage, and at resident and family council meetings. So going back to our case study, this actually took place during Iowa's statewide pilot study. So there was a lot of training taking place between all of the different team members. There was a lot of communication among the healthcare team members just because this was still a pretty new process for us. So nursing homes are connected to numerous community partners. You've heard from several other settings in the previously presented webinars. You'll have a lot of overlap. So the top graphic depicts the different toolkits, but if you think about it, might be a little easier to visualize the relationship among all of the settings as more of an overlapping. So in the bottom graphic, you'll see the nursing homes in the middle, and that we're actually connected with all of these other sites. The primary care could include different health clinics, independent living, assisted living centers, adult day health centers, senior centers, private caregivers, home health organizations, prisons, etc. The EMS trauma could include your city, your county, private ambulance providers, first responders, EMS. Hospitals could include both public and private hospitals, as well as Veterans Health Administration centers. Hospices follow people in a lot of settings, so there's a lot of overlap there as well. And then other community sites to consider, like education and schools, religious leaders, lawyers, and faculty and students in higher education. So a lot of places that have academic centers, you have young people in training for their health professions. It's a great place to engage people as well. So in our case study, we did have a little bit of overlap between our resident because she was in the nursing home, but I had actually reached out to her primary care provider who followed her in the when she lived in her in-department. So I touched base with them to figure out what they had already documented, what they had known about her wishes when she was living in an independent setting. So the POLST forms in nursing homes is advised that you keep them in the front of the chart, usually in a protected sleeve. And what we find helpful is if you put a sticker on that sleeve, not on the POLST form, but on the sleeve that says, please return to the name of the nursing home and address and phone number and contact information, just in case that the POLST form gets separated from the patient. Like we said, a lot of times in nursing homes, there's transfer between a lot of different settings. So if it's maybe left at a hospital, for example, we want to make sure that they know where this person, which nursing home this person lives at. If your policies and procedures is not to keep the POLST at the very front of the chart, then maybe an alternate place could be in the legal section, or sometimes nursing home charts have an advanced directive section, even though it's not, it's an order, not an advanced directive. Sometimes that section of the chart is a good place to keep it. If a nursing home uses a fully paper chart, it's a good idea to have some type of an indicator on the outside of the chart so that people know that this person has a POLST form in the chart. For nursing homes with a hybrid paper chart as well as some electronic medical records, it should be indicated somehow on the electronic face sheet when you sign in to see that the person does in fact have a POLST, so people know to look there. So just some type of a visual indicator. For people with a fully electronic medical record, it's good if you can indicate it also on the face sheet. And then usually what happens is there has to be a binder or some other place where the actual POLST forms themselves are kept that are not, that are there to be taken if somebody's transferring out. So in our case study, the POLST form was kept in the front of the chart in a plastic sleeve with the contact information for the facility on it. So how can this POLST toolkit help you? It really can help answer a lot of questions about, why is POLST important? It's based on a lot of research and best practices. We hope that it's going to be used as a systems-wide tool. So like with many of the other webinars that have already been presented, there's a lot of systems that are involved, so having a reference to look back to. And, in our toolkit, we have a lot of examples, like I said, how-to information in there. It's important to be able to provide education to staff, the residents, their surrogates, and family members, as well as increasing communication among all key healthcare providers across various settings, also supporting nursing home residents as they transition through different settings, and providing nursing home-specific resources, including best practices, example policies, and frequently asked questions. So like I said, POLST is a part of best practices. There's been a lot of different research that shows good evidence. This is one area that is also going to be highlighted in the hospice chapter. That's an example in that chapter toolkit. So let's look back to our case, a little bit of follow-up. So a few months after the IPOST was completed for our resident, her son had gone back to the East Coast. She again had some symptoms of another stroke. And of course, this happened in the middle of the night. So the nurse called the son first to report that these symptoms were happening. And he said in the middle of the night, please take her to the emergency room. I happened to be the nurse practitioner on call that night. And when the nurse called me to report all of the symptoms that were happening, what was going on, I said, okay, wait a minute. I recall that her IPOST indicated that she was a DNR in Section A, that she only wanted comfort measures in Section B, which says no transfer to the hospital, and she had indicated no artificial nutrition per tube in the Section C. So I informed the nurse of her wishes were to, in fact, remain in the nursing home, and that she opted instead for comfort measures, that she would not have wanted to go back to the emergency room. So the nurse actually touched base with the son, who actually then realized, yes, that is what she said, that is what she wanted, and was okay with that, remembered that, after his kind of stress level and anxiety came down a little bit, that he did want to do what his mom wanted, and let her stay in the nursing home and did not send her to the emergency room. I actually was able to follow up with the patient the very next day when I was visiting the campus of the retirement community. I wasn't there to see her, but I did stop in to check in on her. And she actually was able to die peacefully just a few days later, and she was not in any pain. And so she got her wishes that she had wanted were followed for her. So I'll hand the webinar over to Merce so she can tell you about evaluating how your nursing home implementation is going.
Thank you, Nicole. And I think it's really helpful to have an actual case study showing how this can work. Thanks for sharing that with us. We're spending some time during this webinar to talk about evaluating your nursing home's use of the POLST paradigm, because it's part of good patient-centered care, person-centered care. And in order for you to have confidence that you're providing the best care possible, it's good to be deliberate about how you set up your systems and then how you evaluate your systems, so that you can keep tweaking the system and provide even better care. So we're encouraging nursing homes to use the information that we're going to be talking about to help enhance and maintain their policies and procedures. So we're talking about structural changes and policy changes. And by making sure that you have sound policies and procedures, then your staff will be more likely to know what's expected and how to do it. And that can provide better care for everybody. Our bottom line with POLST is, are people getting their wishes honored? Is the nursing home resident getting his or her wishes honored? And that the likelihood that they are getting it honored increases when there's a thorough conversation about their status and preferences and goals, and then that their wishes are documented on the POLST form. So what can we do to improve the concordance between what our residents say they want in terms of medical care and then what they actually receive? And so what we're going to talk about in these next couple slides are different ways that you can look for clues as to whether or not you're providing the best care possible, and how you might be able to even improve the care that is provided. We're looking at a model where our outcome here in this green square, our outcome in terms of using the POLST paradigm in the nursing home, is that the resident's wishes, as expressed in the POLST form, those wishes are consistent with the treatment that the resident receives. That's the outcome we're headed for. That's the outcome we want. Now, not all residents are going to be needing their POLST form to be considered all the time, of course. You're only going to use the POLST form when medical decisions have to be made. So we're talking about ways that you can look at how your nursing home is structured and some of the processes, how those are set up, so that even if not all your residents need their POLST form pulled out and acted upon, you can still have a pretty good idea if you're set up for success. So we're talking about good structures in a nursing home plus good sound processes. That equals good outcomes. And sometimes if we're not able to truly evaluate the outcome for whatever reason, we can get clues about whether or not we're likely to get the outcome by looking at how our nursing home is structured and the processes that are in place. And so I just wanted to talk a little bit about some examples. Let me go back and say, these examples I talk about, it doesn't really matter if it's a structure or a process. They're both clues about what the outcome is going to be. So some examples are, does the nursing home have adequate staffing? So if the structure is not set up to be able to provide person-centered care because there aren't enough people, or they're not qualified, or they're not trained in POLST, there's going to be problems right there. So making sure that people are assets, your staff are assets, and so making sure that your assets are well prepared to understand the paradigm and then follow through. That's going to be very important. What are the procedures that your nursing home has developed to obtain verbal orders? And so that can be used internally, and then to make sure that the signature is secured. All these little steps should not be left to the discretion of an individual staff member. These things, these structures and processes should be decided by the nursing home and then communicated well and then reinforced. And so that way you're setting up a good sound structure. What is your nursing home's policy for voiding a POLST form or for changing a POLST form that's already completed? What's your nursing home policy for addressing ethical issues that might come up with POLST? These are system issues. How are residents screened for appropriateness for POLST conversations? How is the result of the screen documented? So you're having an actual screening. Somebody is deciding whether or not to invite the person to have a POLST conversation, and then having the conversation, and then getting the proper decisions recorded on that form, and then having the form signed. The nurse or the social worker who are trained in POLST and who are right there in the setting, they may be starting this conversation. They may be having pieces of this conversation. The conversation can happen more than once. It can be a process. But it is the person who is the primary care provider, who is licensed as a primary care provider in that state, who must sign the form saying that he or she recognizes that the form reflects the wishes of that resident. And in some states, there are places on the POLST form for another health professional to sign that they talked with the family about this, but it's the primary care provider whose license is on the line to say that these decisions reflect what the resident would like. So how is your nursing home going to be conducting these conversations, and when and by whom? These are all decisions that nursing homes need to make. We've got over 15,000 nursing homes in this country, and there are going to be lots of different ways that a POLST paradigm can be structured so that it leads to good care. And those ways are going to be, some of them are going to be unique to your nursing home and unique to your state, because state rules related to POLST and related to primary care professionals are different. All right, let's give a few other examples. And in our toolkit, we have lots of different examples about things that could be considered to be decided upon by whichever group in your nursing home is going to be developing the POLST or keeping the POLST going. So are you reviewing the POLST form at your care plans meetings? Are the review being documented in the chart? Do you have a policy about where the completed POLST form is kept. Nicole alluded to that a little bit. It came up in our sessions when we worked intensely with the 2 local nursing homes that when people were going out to the casinos and some of the residents had POLST forms, or well, what would be the process for the activities director to take those POLST forms with them to the casino, and then how do the POLST forms get back into the medical chart and all that kind of stuff. Those are procedures that need to be worked out at your nursing home's level. And then if there's a discrepancy between what the resident indicated he or she wanted on the POLST form and then they didn't get that, what happened? You know, how was that able to occur? And so you might realize as I talk about this, it sounds a little bit like QAPI, right? The Quality Assurance and Performance Improvement processes that the CMS is expecting and encouraging from nursing homes. And that's true. Looking at POLST would be a lovely QAPI project. I'll talk a little bit about that in a couple slides. I just wanted to give an example about how some of this might be done. So your nursing home team that is implementing the POLST paradigm, you should have a target about what percentage of nursing home residents who are appropriate for POLST, what percent actually have a completed POLST form. And so let's just pretend you have 120 residents and that you've decided that 68 of those 120 are POLST appropriate, and that there are 39 who actually have a completed POLST. So you would calculate 39 divided by 68. 57% of the people who are appropriate for POLST in your nursing home have a completed POLST. And now you're going to need to decide, is that good enough? Do you want that to be 70%? Do you want that to be 80%? It probably will not be 100% because engaging in the POLST paradigm, and especially getting that form, is voluntary. So even if you invite all the POLST appropriate residents to engage in that conversation and have a form, you should be inviting them, but whether or not they choose to do it is always up to them. That's the self-determination part. So come up with a realistic percentage and then track the extent to which your nursing home is keeping up with getting completed POLST for people who are appropriate. Here in Iowa City, we have an Honoring Your Wishes project. It's an advanced care planning project for our whole community, and they have developed different forms. These are all in the Toolkit as well, and other places around the country have developed forms that could be useful to you. You don't have to reinvent the wheel. So check the Toolkit on the National POLST website when the toolkits are finalized, and you will be able to tap into a lot of other work that people have been doing. You want to basically be able to know with confidence that residents' wishes are being honored. And then one measure of that too is after the resident dies, to see if the care that they got at the end of life was consistent with what they said they wanted in POLST. Another pretty straightforward way to look at how your nursing home is doing is to look at the POLST forms that are completed and to make sure that they're fully completed. By that I mean each section of the POLST indicates a decision and all the appropriate signatures are there. You'd be surprised how many POLST forms are put in medical records that are not complete or haven't been signed off appropriately and all sorts of things. So that could be a project that you do right there. Of course, if you have a POLST form, you want it completed, and especially you want those signatures there. All right, so you want to be able to think about collecting information that could look at how your nursing home structure and process should be contributing to the outcomes that you want. You want to be identifying areas for improvement, always looking for ways to get this better. And as Nicole explained, it looks like a pretty straightforward form, but the devil's in the detail, because often in the nursing home setting, we're dealing with a lot of different systems, not just the nursing home. We're dealing with hospice, we're dealing with the emergency departments, we're dealing with EMS. So all these pieces and transfers need to all be on the same page, and that takes a lot of work to do that right. And so tweaking, assessing, and then making sure that you celebrate your successes. I mentioned a little bit about QAPI. Those are the new nursing home federal regulations that went into effect last November. Now CMS is asking for more feedback as to whether or not they're going to require QAPI and what they'll be requiring. But either way, it's a good policy to have ongoing quality assurance performance improvement projects. And each nursing home is going to set up their own team, and they're going to figure out what they want to do, what they want to look at to improve care. But one of the possible issues is the POLST paradigm right in your nursing home. And so let me go back to this for just 1 minute. Some of you may not be familiar with QAPI as an acronym there, but you've probably heard about the some of the other terms that have been used, like the root cause analysis or the 5 whys or the fishbone, different ways to organize information and data to ensure that you're doing everything you can to set up proper systems. And if the nursing home systems are set up appropriately, you're more likely to give residents the kind of care that they want. Please remember that POLST form completion is voluntary. Residents do not have to have a POLST form. And we have worked with some, I've talked with some nursing homes and heard some things through the listserv where people are, nursing home staff are mandating POLST or want to mandate POLST completion, absolutely against the spirit of POLST. This is voluntary. If residents don't want to have that conversation for whatever reason, or they don't want it documented, it is their right to not have a POLST. The surprise question, please remember that. That's one way to tell whether or not a person is appropriate for POLST. POLST forms can be changed or revoked by the resident and or the family at any time. These are treatment wishes. You can underscore with residents and families that comfort measures are always appropriate, and also that people have the right to decide what kind of treatments they want under different kinds of conditions. And these POLST forms should not be completed without a thorough conversation or series of conversations. It needs to be informed from the resident's point of view, or if the resident is being represented by a surrogate. They should not be asked to make these decisions without a thorough discussion. The National POLST website is working with POLST Paradigm partners in many different states. The state laws vary. How the paradigm has been folded out and unrolled varies a little bit, but just know that you've got resources that you can turn to get some help. And I just want to take a few other minutes to say a few other things. You can touch base with your with the National POLST Paradigm in their website. You can click on the state on this map, and it'll tell you who in your state is working on POLST. They're not necessarily all nursing home people, but they're people who are informed and wanting to work with others to help you get the best POLST paradigm possible in your setting. There's QIOs, the CMS Quality Improvement Organizations that every state has a QIO assigned to it. You can ask for help on POLST from your QIO. I'm in a school of social work. Nicole's in a college of nursing. We always are looking for community-based projects to help people with. So if you're a nursing home and you're a little intimidated about figuring out how you're going to track your success, contact the local social work school, nursing school, public health school, and there'll be some expertise there once you find the right person who can help you set this up. Just know there are lots of resources. There are a lot of people committed to making this happen and to work out. Please, would you raise your hand if you are a nurse working in a nursing home? Please raise your hand electronically and keep your hand raised. I just want to get a sense of how many nurses. I see 2 hands raised, but all right. So I just want to know about how many nurses are here. Okay. And now if you're a social worker in a nursing home, please raise your hand electronically. Nurses, keep your hands up, because I also want to just have a sense of how many people are actually working in nursing homes as a nurse or a social worker. If you're in any other capacity working in a nursing home, would you please raise your hand? If you are a staff member, an employee of a nursing home. All right, so that kind of gives us an idea and probably help us too when we address your questions. We want to acknowledge Pew Charitable Trust for the funding of the National POLST organization to develop these toolkits and also to develop the webinars. So now let's turn it over to you. You can put your hands down now, but thank you for letting us know. One other thing I want to say, that when this webinar is over, after we address your questions, there'll be an evaluation form set up, and we would really appreciate you taking a few minutes to give us some feedback. I'm going to turn it over to you, Hannah, and you let us know what questions there are there that you'd like us to address.
Yes, absolutely. Thank you both so much for the webinar today. We have a number of questions that came in, which I'll read off to you, and we'll do our best to get them all answered. And we may go over the hour just a few minutes to make sure we address all your questions. So the first one actually goes back to slide number 5, and the question is, what if the nursing home never has that conversation and the POLST is old and not current?
So I can go ahead and answer that. So it's required,
Sure.
Recommended that you do review it at regular intervals, and usually depending on your state, that's kind of outlined right on the back of the form, so you have an idea. But definitely, if there's a change in health status, that is the time that you want to revisit that, review it, and then revise it if it needs revising. It's okay if that conversation happened by another provider in another setting. It's still, if they've had a change or if it's been a while, you still want to go ahead and revisit that.
And I would just add, the revisiting does a few things. For one, it communicates to the resident and the family that you're open to talk about these things, that you're a resource as staff members or as the primary care provider, and that it's okay to talk about these kinds of things. You're giving them permission, and you're modeling by the way you respond and the way you ask these questions that these are completely appropriate conversations to be having, and that you can help connect them to answers and questions. It's not just the information, it's also the emotional support to think about the questions that we're posing to residents and posing to family members. Giving them information and then also that emotional support to help them make sense of it and come up with decisions that are going to lead to peace of mind for them and connect them with the kind of care that they want.
Great, thank you. Another follow-up question from that one. What if a nursing home does all the wrong things per an old POLST form? And I think this was going back to your slide number 6. I think there was a case study with a stroke patient.
I didn't warn you to get some Dramamine, but I'll go back to slide 6 while I think that was yours, Nicole.
I think that was, yes.
So
I can read the question.
Could you read it again? Sorry.
Of course. What if the stroke is not recognized and the nursing home does all the wrong things per an old POLST form?
So the POLST form, that's a medical order. So it is imperative that you're following the correct version. And then I'm not sure what you mean by old form, but when you revise or create a POLST form, the previous version needs to be voided. So you would actually, just like you would, in the paper chart, you would draw a line through it and write that it's voided and write the new order. The new POLST form becomes the new order. So I'm not sure if that's kind of what you're getting at, but the POLST form is a medical order, so you do need to follow what's on the order. Is that, I'm not sure if that's answering the question.
With the insinuation that the nursing home staff does everything that's wrong, that's the, I think, part of the issue. The POLST form is an actionable medical order directing what kind of care should be provided. That speaks to the importance of keeping it current. If the resident has the stroke after the POLST form has been completed, but a new POLST form hasn't been completed yet, you need to follow the actionable medical order, the POLST form that was there. So whether, it's hindsight can be 20/20 in terms of whether it was right or wrong, but in terms of the actionable medical order, the person has said, this is the kind of care that I want now. And then when their situation changes, it's time for another conversation. But the person might have a stroke at 9 o'clock in the morning, and you're not going to get another POLST form made by 9:15 or 9:30 because you want to have a conversation. This needs to be deliberate. And so, yes, I suppose it's possible that there may be a lag, but then you want to, when there's a serious change, that the resident always has the right to change their mind about what kind of care they want or don't want, and they have the right to reinforce that is what they want. And this is one way to communicate it. So if the nursing home is following what the POLST form says, and then they should be doing what the person said they wanted.
Great. Thank you for that thorough response. The third question for you, can any team member initiate the POLST conversation, or should it be a nurse or MD?
It should be somebody who's trained in advanced care planning. And different states have different scopes of practice for different levels of nurses and for social workers, but whoever is engaging the resident or the family needs to be well prepared and emotionally comfortable engaging in advanced care planning discussions, including the physician. The physician or other primary care provider needs to be prepared. They need to have some training. If they didn't get this in med school, and most of them didn't, or in other kinds of professions, residents and families deserve to be interacting in these conversations with professionals who have been prepared to have these conversations. If the residents have or family has detailed medical questions, then that goes to a medical professional or an advanced practice nurse. But if the resident or the family knows the prognosis or the diagnosis because they've already had multiple conversations over years with their primary care provider, and now it's a quarterly care plan meeting and they're thinking about whether or not to keep it the same or change the POLST, yes, it would be completely appropriate if the resident and the family know what they want to make sure that those wishes are reflective. Still, the primary care provider is going to have to sign off on that. And so in many cases, a primary care provider may check back with the resident and or the family, or they've recently had that conversation and they know that that's reflective. Nicole, as a primary care provider here in Iowa, do you want to talk a little bit about how you as a non-physician work with residents and families on their POLST forms?
Sure. And actually, let me just add to kind of answer that question a little bit too. The biggest thing is if you're acting within your scope of practice, whatever that is, so physicians, physician's assistants, nurse practitioners, nurses, social workers, but also chaplains, and a lot of times are trained in having the conversation. So it's if you've received training and it's appropriate for your scope of practice. So that's kind of the thing that I'll add, because we do have chaplains here that also initiate the conversation. And yes, I actually as a nurse practitioner in long-term care, I've either initiated the conversation myself with residents or the nurses in the nursing home or the social worker, either or all. Sometimes we have multiple conversations between a number of people on the team before the person is able to really hone in on what their wishes are. So it's it's an involving conversation that as people's healthcare status changes, a lot of times their goals change. So many people have this conversation. It's one of the key things is how well do you communicate that among your team, and how well do you document that in the medical record so that people are comfortable with completing the POLST form.
All right, thank you. I think I'm going to go ahead and move on to our next question that we got. It's referring to slide 15. How do you enforce that requirement to review the POLST with a change in health status?
How to enforce it is basically, if somebody's had a change in their health status, maybe if they have questions, refer that back to the PCP. Otherwise, it's just you have another conversation. How has this change in whatever's going on, does it affect your goals of care? Like, do you still have the same goals, or now maybe you've decided you don't want to go back to the hospital, so you want to change your level of treatment? So just kind of revisiting, like now that we know that this is your new normal, what, are your goals of care the same?
And, this is what CMS is expecting of any certified nursing home in the country anyway. Every time there's a major change in status in a nursing home, you're supposed to be, for a resident, the care team's supposed to be sitting down and figuring out now, this person, was sent to the hospital or had a major stroke or whatever. You're already required to sit down and figure out if the care plan is the right care plan now. And so this tucking in the POLST as part of that is completely consistent with what good care is anyway, and it then takes what might be discussed within that care plan meeting and then including the primary care provider as well and the resident and the family and getting the POLST form up to date. So, if a CPR decision comes up, whether or not the staff know what the person wants, they still have to make a decision. The staff still has to make a decision. And so the POLST is, like other tools, a way to encourage discussion before an event happens so that we have an inkling or a clear idea of what the resident and or the family would like. And at that point, let me also say, this is the importance of also having a durable power of attorney for health care. For your residents should have a durable power of attorney for health care. Of course, if you are working with somebody with dementia, it's too late for them to have a durable power of attorney for health care, especially if they have moderate or advanced dementia. So when somebody has a durable power of attorney for health care and they've identified who that durable power of attorney is, their spouse, their son, their neighbor, then let's say the resident has a massive stroke and can no longer communicate, and doesn't have a POLST. Well, they do have a durable power of attorney already identified, and so now that person can engage in the POLST conversations and the POLST form can still be done. So you still want to have that durable power of attorney for residents. You want to offer that to them if they want to have it.
Thank you, Merce, for that comment. There's a question that relates to having a durable power of attorney. The question is, if the resident has completed a POLST, then has CVA or a DX that no longer allows them to make decisions, is the family and or POA allowed to change the POLST?
Yes.
Go ahead.
If they have a POLST and they have a surrogate identified, such as a DPOA, they are allowed to make a change on the POLST. we want to make sure that we remind them that their role is to make the decisions that the resident would have wanted for themselves if they were still able to communicate. So not what the POA is interested in, but what the POA thinks the resident would want for themselves.
The POA is voicing what the resident would voice if the resident could. So the POA is representing the wishes of the resident. And I'll mention that in the toolkit, we talk about surrogate decision makers, and we have some best practices talked about in the toolkit, and there's also some frequently asked questions in our toolkit. And you can check with your state resources and the national POLST resources. There's been a lot of questions and interest in how POLST Paradigm works with surrogate decision makers, and this, of course, is particularly relevant in a nursing home setting where you have so many people with dementia. So even if we don't answer your questions thoroughly today, those questions have been asked by others and answers have been developed, and you have resources to consult.
Great, thank you. We do have quite a few more questions, and I don't think we'll quite get to all of them, but if you don't mind answering one more. The question is, nursing homes are using the POLST as their code orders, so then it's mandatory for all patients. We're trying to educate them that it is voluntary and not mandatory, and encouraging them to use their regular code orders. Any suggestions on how to change or improve this practice?
It goes right back to the processes and the structure set up at the individual nursing homes. The individual nursing home policies should not allow that residents are forced to have a POLST form, because POLST is not appropriate just because you're getting care in a nursing home. The test for appropriateness is whether or not a healthcare provider would think that this person might die in the next 12 months because their health status is that tenuous or that frail. And we have many people who live in nursing homes for 5, 10, 15 years who are not appropriate for POLST that whole time, right? Or people who enter on for rehab, they're not appropriate for POLST. And so the whole paradigm is set up for people who are about a year away from death or considered to be about a year away from death.
Right. And another, just to add on to that, is we want to make sure that people are sitting down and engaging in thoughtful conversations about their wishes. And so by using it as just a DNR form status, that really is not what we're trying to get at. We really want to have these detailed, thorough, thoughtful conversations to elicit what the people want at the end of life. And then, like Mer said, it's for people who are within a year to the end of life.
Great. Well, thank you both so much. We do have a few other questions that I don't think we'll get to today, but if your question didn't get answered, then we'll follow up with through email. I'll make sure and get you connected with the presenters. Merce or Nicole, do you have any other concluding remarks?
I would just like to say, this is Merce, that when the nursing homes go through the effort, and it is effort, to set up sound systems and to set up good policies and to focus on communicating that, you're much more likely to get the kind of outcomes that you want. Otherwise, when problems happen, it's usually the staff member who's blamed. It's blaming the victim of a poor system. And so you can do a lot of prophylactic good staff care and that results in good family and resident care by going through the effort of setting up good policies and procedures related to the use of POLST that will have many, many other positive consequences in terms of building relationships and in terms of building trust and providing that person-centered care. So yes, it is some extra work. It can feel like some extra work, but this is going to, in the end, help provide the kind of care that our residents want. And I also want to thank all of the direct care providers, the nurses, the social workers, the staff members for the kind of work you do day in and day out to help Americans in nursing homes and their family members receive dignity and very good care. We do appreciate the work that our nursing home staff members are doing.
Okay. All right, wonderful. Well, thank you for the fabulous presentation. And yeah, like I said, we'll definitely follow up with you if your question didn't get answered today. And otherwise, I will end the presentation and thank you all for joining. Have a good afternoon.
Okay, and thank you, National POLST Organization, for making this possible.
Absolutely.
All right, bye-bye.